Good morning, guys. So today also we are going to continue on hemorrhage and its management. We have started this topic from the last time. Now we all know hemorrhage is also known as bleeding, bleeding anywhere, either outside the body or inside the body, either from artery, vein, or capillaries, isn't it? Either as a result of surgery or as a result of trauma or some other cut or injury. So there are so many different types or classification of hemorrhage, a very important question for the students. Okay, now regarding the classification of hemorrhage, let's revise a little bit. Arterial bleeding is a bright red blood and it spurts like a jet because it's a pulsatile type of bleeding. And that is how we diagnose arterial hemorrhage. And within a short period of time, a person can lose a lot of blood. Venous bleeding is a continuous type of flow or continuous bleeding. Okay, it is a dark red blood because the type of blood present inside the vein is a deoxygenated blood. As a result of this, it looks dark red in color. And if we give a compression in that area, venous bleeding will stop. Capillary is a continuous oozing type of blood, very minimal type of blood or amount of blood is lost, and it's a oozing type of blood because the blood vessels from where the bleeding is coming are the very small or the smallest type of blood vessels. So it is a ooze or oozing type of bleeding. Okay, so this is one type of classification. Another is according to the timeline. For example, we have done surgery. At the time of surgery or operation, bleeding will occur. You cannot avoid bleeding during surgery because surgery is all about the tissue. We cut the tissue there. We need to enter into the body cavity or certain organ. So we need to give incision, we need to cut the tissue, so there will be bleeding. This is known as primary hemorrhage. Reactionary hemorrhage is another type which occurs within 24 hours. So it is a delayed type of hemorrhage and it is very commonly occur after certain type of surgery like tonsillectomy, thyroidectomy, prostatectomy, and hemorrhoidectomy. I'm sure the meaning is right there for you. Tonsillectomy means after removal of the palatine tonsil, after removal of thyroid gland, removal of prostate in male, and hemorrhoid, they are the piles. Okay, and one of the important surgery in grade 3 or grade 4 hemorrhage is hemorrhoidectomy. We remove those dilated and submucosal vein. So reactionary hemorrhage is quite common in this situation. We'll talk about what are the causes of reactionary hemorrhage after some time. Now, secondary hemorrhage occurs 7 to 14 days after the primary hemorrhage. And a most important cause is infection of the wound. So we need to manage accordingly. Sometimes earlier removal of the of that clot or the scab or some unnecessary trauma in that wound can also result in secondary hemorrhage. Now, another type of classification is according to the site or visibility. That means either we can see the bleeding or we cannot see the bleeding. Means it is occurring inside, we cannot see it. So external or revealed hemorrhage and internal or concealed hemorrhage. Now the question for the students here is how do you diagnose internal or concealed bleeding? Yes, I want to listen to some answer here. How to diagnose internal or concealed hemorrhage? Anyone?
Sir, there will be anemia and also when internal bleeding is occur, the periphery will be cold.
Okay, good. I agree with your answer. Anybody else? Now listen, this is a very important question, okay? And I will ask this question in your assignment also. So listen properly. Whenever there is bleeding going on, either external or internal in our body, there will be certain features of hypovolemia. certain features of hypovolemia, like tachycardia. So let me write those things here for you. Tachycardia is the very early feature of hemorrhage. Okay. After that, if the hemorrhage is extensive or a little bit moderate to severe type of bleeding, there will be low volume pulse also. Low volume pulse. It is also known as, okay, a thready pulse. Okay, thready pulse, fast and low volume pulse. After that, there is cold and clammy periphery. Absolutely correct. Cold and clammy peripheries. Okay, there will be prolonged CRT. Prolonged CRT. What is CRT? I'm sure you know this. CRT means capillary refill time.
Capillary refill time.
Exactly. Very good. Capillary refill time. It is prolonged more than 2 seconds. Okay. Then you can add so many other things here. Patient may be pale. Patient may be pale, but that pallor takes time to develop. In today's class, we'll talk about that. It takes time to develop. There should be hemodilution, then only pallor occurs. So it is not immediate type of manifestation. Then there may be hypotension, but hypotension occurs only if a bleeding is massive amount. Only in shock, hypotension develops. And the type of shock which develops here is called hemorrhagic shock, or a type of hypovolemic shock. There would be oliguria because of the decreased renal perfusion. There may be confusion because of decreased cerebral perfusion. See that? So these all are important clinical features. These are called non-specific clinical feature because they can be present in any type of bleeding. Okay, but you can add another answer now. According to the which type of internal or concealed hemorrhage, we can see some further features. For example, if the bleeding is occurring in the intracranial cavity, remember bleeding cannot be massive in intracranial cavity because the space is not big. Space is not big. Rather than this clinical feature which I have just listed, some space occupying lesion may be present there. Okay, like hematoma in certain areas. And in the last class, I clearly told you there are different types of intracranial hemorrhage. Depends on the in which space it is collecting, like extradural hemorrhage, subdural hemorrhage, subarachnoid hemorrhage, okay, intraparenchymal hemorrhage, and intraventricular hemorrhage. So they cause headache, vomiting, raise intracranial pressure, seizure, all those type of things. Hemothorax is a large area. Remember that the pleural cavity is a large space. A lot of blood can be collected there. So, along with those features which we have just listed, patient will have difficulty in breathing. Okay, faster respiration, hypoxia, and all those things. Because this hemothorax will collapse the lung. Okay, it is a compressive type of collapse. We all know that. We have studied before. Hemoperitoneum is another big space there, peritoneal cavity. So if bleeding occurs there, definitely okay, the person can develop hemorrhagic shock. And during this time, there may be abdominal distension, okay, which can be detected by ultrasound. So you need to take help of some of the investigation sometimes to diagnose concealed type of hemorrhage. There may be some features of trauma there. And in case of fracture, the blood may be collected inside the limb or even in the pelvic cavity. So this is a very good, a concept how to diagnose internal or concealed bleeding. Let's move on. Now, another classification under the hemorrhage is according to the mode of onset, acute bleeding and chronic bleeding. Acute bleeding occurs right now, okay, within a short period of time, like stab injury, punctured liver or spleen. Any type of example you can give here. And chronic, they occur over a long duration. They keep on occurring there. Hookworm infestation is one of the very good example in medicine. Hookworm infestation. Now, can anybody tell me what are the names of those hookworm? Yes?
Ascaris.
Ascaris is roundworm, okay? It's a giant roundworm. So any other name you remember?
Sir, sir,
Yes?
Nessator, sir,
Ankylosarcoma duodenale.
Very
sir,
good.
Nessator,
Nessator
Americanus,
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 Very
and
good.
Ancylostoma duodenale.
ankylosarcoma duodenale.
Exactly. Exactly. Okay. Ankylostom duodenale and Necator americanus. Ankylostoma duodenale and Necator americanus. Now, let me write this here for you. See here. This is the way you need to revise the things, okay? Ankylostoma duodenale and Necator americanus. Don't forget, these are the scientific name of hookworm. Okay, Necator americanus is slightly bigger than Ankylostoma duodenale, and it also sucks a little bit more blood than Ankylostoma. Duodenum is the main area where they lodge themselves, and they keep on sucking the blood. And over a period of time, they cause iron deficiency anemia. So one of the very important cause of iron deficiency anemia is hookworm infestation. And we can easily diagnose them by stool examination. There will be egg of the hookworm present in the stool. And another way is diagnose iron deficiency anemia. Okay, I'll take a class regarding all these anemia in pediatrics. I'm moving there very soon now. Only few topics are left. Okay, so during that classes we will talk about how to diagnose. But right now you want to know about that. We call it iron profile study. So serum iron level, okay, is one. Ferritin level is the second, and transferrin, okay, which is known as total iron binding capacity. All these things will check apart from peripheral smear and CBC. We always do that. So this is the easier type of diagnosis. Another cause of chronic bleeding is a bleeding peptic ulcer. Peptic ulcer is a chronic condition. And there are two types of peptic ulcer. You all know, gastric ulcer and duodenal ulcer. Both of them can bleed over a long period of time, and they can again lead to iron deficiency anemia. All these chronic blood loss leads to iron deficiency anemia. Remember this. But acute blood loss will not cause iron deficiency anemia. It causes normocytic normochromic anemia. Iron deficiency anemia is an example of microcytic hypochromic anemia. Okay, so there is a difference. Hemorrhoid, another cause of chronic blood loss. Menorrhagia. What is menorrhagia?
Menstrual period with abnormally prolonged bleeding.
Menstrual cycle.
You're absolutely correct. This is a prolonged and abnormal menstrual loss. Prolonged and abnormal menstrual loss means the blood loss during period or menstruation is excessive. This is called menorrhagia. It is again a cause of iron deficiency anemia, an example of chronic blood loss in female. Cancer, cancer of the GI tract. Okay, cancer of GI tract. I will give you a good example here. That is right-sided colon cancer. We have studied that before. Right-sided colon cancer usually leads to iron deficiency anemia because of prolonged bleeding, whereas left-sided colon cancer usually causes intestinal obstruction. So these are some of the good examples. Let's move on. Now, according to the cause, hemorrhage can be surgical or non-surgical. Quite an easy type of classification. Surgical occurs during surgery or operation. It is the result of direct injury. And it is easy to control also because the surgeon is right there to control it, right? If we put suture there, if you tie the knot, the bleeding will be controlled. Or it can be controlled by electrocoagulation also. Whereas the causes of non-surgical hemorrhage can be so many, mainly the medical causes like bleeding disorder, okay, clotting disorder. A good examples would be coagulopathy and DIC. Coagulopathy and DIC. Now, every student know about DIC because we have talked about that, okay, before, and there are so many causes of coagulopathy. The most probable cause or common cause which comes in your mind is liver disease, chronic type of liver disease like cirrhosis of the liver or chronic hepatitis are the common cause of coagulopathy, okay, in clinical practice. So many others are there. Okay. Now, one important difference between surgical and non-surgical hemorrhage is in non-surgical, there is a generalized oozing from all raw surface as a result of DIC or coagulopathy. And it cannot be stopped by tying the knot there. We need to compress that area with packing, okay, with a gauze. A lot of gauze pieces will be necessary, and we pack that area. We give a bit of pressure, and after some time, it will be stopped. Whereas surgical hemorrhage, we tie the knot there. Which artery or which vein is bleeding, we find that out and tie the knot or tie that blood vessel. The bleeding will stop in surgical hemorrhage. Now, let's move on to the reactionary hemorrhage. In this case, we already know the definition. Bleeding occur within 24 hours of primary hemorrhage. Okay. Remember the definition. So there has to be certain cause, isn't it? And regarding the cause, there is slippage of the ligature. Okay, the slipping of ligature. Ligature is a knot or the suture material which we have tied there. So somehow, if it slips out, then there will be bleeding. There's no doubt about it. Okay, there will be bleeding. After that, there is a dislodgement of the clot. The clot which has formed there is dislodged, and there is cessation of reflex vasospasm. Immediately after the trauma or surgery, remember what happens to the blood vessel? It will undergo spasm. That is the first mechanism by which bleeding stops. After that, the coagulation pathway will come into the picture. In between, there is a function of the platelet also. Okay, we have studied that in physiology. First, there is vasoconstriction, then there is a platelet plug formation, then there is a clotting or blood clot formation, which is known as fibrin clot. So if this reflex vasospasm is over, then there is a chance of hemorrhage. Chance, okay? There are so many other factors involved. Now, what are the predisposing factor for reactionary hemorrhage? If the patient is having increased blood pressure, there is increased pressure given to that blood vessel, and there may be slippage of the ligature or dislodgement of the clot, and bleeding can occur easily. Restlessness, okay, quickly after the surgery. That's why we ask the patient to take good rest. Do not move around too much during that time. Coughing and vomiting will increase the pressure, okay, inside the cavity, and reactionary hemorrhage can occur easily. Okay. Now, what are the common surgical procedure after that reactionary hemorrhage occurs? Already seen this list. A common are after tonsillectomy, after thyroidectomy, after prostatectomy, and after hemorrhoidectomy. Reactionary hemorrhage is quite common to occur. Okay. Now, how to prevent and how to treat if this reactionary hemorrhage occurs? Regarding the prevention, we have to carefully examine the wound. Okay. Why it is occurring? Is this because of slippage of the ligature? Is it because of dislodgement of the clot or something else? We need to find that out first. So that can be possible only after examination of the wound. Careful closure of the wound during surgery should be done. Then there is no chance of slippage of the ligature. If an inexperienced person is doing surgery, the experienced surgeon, of course, should monitor how that person is tying the knot. Okay, otherwise there will be a disaster. For example, the surgeon has done appendectomy. Okay, the appendicular artery was tied by the inexperienced person, and he did not know how to tie the knot. And after completing the surgery, reactionary hemorrhage occurs because of slippage of ligature. Now you have to open that wound again. You need to enter into the peritoneal cavity again. You need to check what is happening there and do the necessary thing, isn't it? So patient suffers from a lot of trouble, unnecessary trouble. So this is an important point to note. If the patient is having cough, okay, or some respiratory disorder or diseases, we need to go for the treatment of that, because cough is not good after surgery. That cough will increase the pressure inside the body cavity. Restlessness and vomiting also should be treated. Regarding the treatment, after it occurs, now we cannot prevent it, right? We need to go for the treatment. So what should we do? Reopen and tie the vessels. Reopen that area. If you need to reopen the peritoneal cavity, go for it. Okay, do not hesitate, because patient is losing blood there. And according to the necessity, go for blood transfusion. If there is severe anemia or hypovolemia, we need to go for blood transfusion as well. So these are the management points. Another type of bleeding is the secondary hemorrhage. Now, according to definition, here the bleeding occurs within 7 to 14 days of primary hemorrhage. And the most important cause is sloughing of the wall of a blood vessel because of infection. Now, let me underline this for you. So see there, the most important cause is sloughing of the wall of a vessel caused by infection. Remember this. That's why it is taking a bit of time to develop. Another cause may be pressure necrosis, or even some of the malignancy, but they are not very common. Malignancy is a extremely rare cause of a secondary hemorrhage, but pressure necrosis can occur after surgery. Now, regarding the management of secondary hemorrhage, we have to remove that infected slough or blood clot, because that is infected already. Okay, we have to remove that infected content. Send the wound, okay, for culture and sensitivity, and that is done by taking a swab from the wound and send that for the microbiology lab, and they will give you the report which organism is responsible. Change the antibiotic to broader spectrum if you have already used one type. We are not satisfied now, so change that into the broader spectrum, or upgrade that antibiotic. Okay, it is called upgrading of antibiotic. Now, what is the meaning of upgrading? Let me give you one example here. If you have started amoxicillin with clavulanic acid in the beginning, now upgrade it to vancomycin, because that was not enough now. After receiving culture and sensitivity report, continue it, okay, if it is working, or change the antibiotic accordingly, according to the sensitivity report. That is what sensitivity report is all about. It will clearly telling you like which organisms are grown there and which antibiotic will kill those organisms or decrease the multiplication of the organism. If necessary, go for blood transfusion. So what is the take-home messages from secondary hemorrhage? It is mainly caused by infection. So I want to find out which infection is there and go for the treatment. Now let's move on to some other aspects of the hemorrhage. If hemorrhage is massive, okay, the person may develop hemorrhagic shock. This is a type of hypovolemic shock, and this class was already taken, if you remember. So according to the amount of blood loss, okay, there are different classes of circulatory failure or hemorrhagic shock. Class 1 to class 4. Now, class 1, when the blood loss is up to 15%, that is less than 750 ml of blood loss, the features are normal here. The features are normal. So rather than this is a classification of hemorrhagic shock, I can say this is a classification of hemorrhagic shock, okay? Because At 750 ml blood loss, no hemorrhagic shock will occur. In class 2, the blood loss is more now, up to 30% of the blood volume. This is a percentage of blood volume. So up to 1500 ml blood is lost. And the person will have pallor, the person becomes thirsty, and there are features of tachycardia. Still, it is not very worrisome. Class 3, the blood loss is up to 40%. Now 2000 or 2 liter of the blood is already lost. Now the person will develop hypotension. Okay, see this? Fall in blood pressure. Tachycardia is already there. Oliguria and confusion. When the blood loss is more than 40% or more than 2 liter, now this is a very serious situation. Now this is a frank case of hemorrhagic shock. There is hypotension, there is rapid pulse, which is called thready pulse. There is decreased urine output or no urine output at all. Anuria means no urine formation. The patient will be unconscious. And what is MODS? What is the full form of this?
Multiple organ dysfunction syndrome.
Excellent. Multiple organ dysfunction syndrome, it is commonly seen in a case of shock because there is a decreased perfusion of multiple organ in our body. And this is how a patient die in case of shock. Okay, so this is a good type of classification. Now we have reached to this state where we can, tell some of the clinical features of hemorrhage. If this question is asked to you, you should feel yourself lucky because the answers are very easy. Now, see there. Okay, let's go through the list. It again depends, okay, on how much blood loss is there. How much blood loss is there? Okay, this is the important point. See there. Pallor and thirsty, okay, are some of the very common features of hemorrhage. Pallor means anemia, and thirsty because of hypovolemic condition. Tachycardia and weak or thready pulse, very, very important point of hemorrhage. Never forget it. Tachypnea is a faster breathing. Okay, faster breathing is also very common feature of hemorrhage. It usually occurs in a moderate to severe type of bleeding. Moderate to severe bleeding. Air hunger. Now, what is air hunger? Maybe some of the students can answer this.
Rapid breathing.
Good. One is rapid breathing. Anything else?
So basically, so the drive to breathe is very high. So it might be during the exercise or sort of infection happens due to that. So when the
Increased respiratory drive.
Okay, good. Now, maybe we have not talked about this in the previous classes. Okay, so please pay attention, all of you. Air hunger is very deep type of breathing. Definitely, it is a bit faster, but more important point here than faster breathing is a deep type of breathing. It is known as sighing respiration, and it is a feature of acidosis. This is a feature of acidosis, okay, especially metabolic acidosis. Now, you may be wondering, what is the connection of metabolic acidosis and air hunger? Now, please listen properly. In case of hemorrhage, okay, if there is a severe type of hemorrhage, moderate to severe hemorrhage, there is decreased tissue perfusion. We all know that. Because of decreased tissue perfusion, there is anaerobic respiration going on in the tissue, and lactic acid will form. This causes lactic acidosis. Okay, so it's a type of acid collection in the body. So this is an example of metabolic acidosis. In metabolic acidosis, okay, the type of breathing which is seen is a deep sighing type of breathing, and this is known as Kussmaul breathing. So see there, Kussmaul breathing. So if they ask you what is Kussmaul breathing, now you can answer confidently. Kussmaul. Let's move on. Sweating is a very important feature, sweating, because sympathetic system is stimulated in case of bleeding. So sweating occurs along with vasoconstriction. And as a result of vasoconstriction, there is cold and clammy skin. Okay, cold is because of vasoconstriction. Clammy means sweaty. Okay, because both of these are functions of sympathetic nervous system. So we often talk them together. Excessive sweating leads to clammy skin, and because of vasoconstriction, the skin is cold. Peripheral cyanosis is common to see again because of vasoconstriction. In case of very severe hypovolemia, even central cyanosis can be seen. There will be dry face, dry mouth, and goose skin appearance due to contraction of erector pylorus muscle. Now, this erector pylorus muscle is connected with the hair follicle, and these are supplied by sympathetic nervous system again. That's why there is contraction of this erector pylorus, which leads to, those hair will become straight now. Straightening of hair on the skin is known as goose skin appearance. A very easy type of explanation, all because of excessive sympathetic stimulation. Oliguria or anuria, features related to specific causes. Don't forget that. What is the cause of this hemorrhage? Is it because of hemothorax? Is it because of hemoperitoneum? Is it because of compound fracture or open fracture? Is it because of pelvic fracture? Is it because of severe cut injury? Is it because of gunshot injury? Okay, so many causes are there. So features are there related to the specific causes. And don't forget about low blood pressure or hypertension. This is not the early feature. And sometimes what the student think, till now there is no hypertension, so this case is not serious enough. Please don't think like that. Hypertension is developed only in the late stage of hemorrhage. So these are some of the clinical features. Let's move on. Now, we have reached to the last part of this very important basic topic, how to, measure the acute blood loss and how to manage the blood loss. Okay, so let's talk about that. How to measure it first, how to estimate how much blood is lost. The adult human has approximately 5 liters of the blood. This is an average. Some people may have more amount of blood than this, some have even less amount of blood. It depends on the body weight. So one very rough guidance is there for us, that is 70 to 80 ml per kg of blood in children and adults, and 80 ml per kg in case of neonate. Okay, in case of neonate, we roughly say we have around 8%, okay, 8% of the blood out of our body weight. So if a 50 kg person is there, that person has roughly 4 liters of the blood, because 50 kg, 8% of 50 kg is around 4 liters. Okay, so this is how you quickly find out how much blood is there in the patient's body. Estimation of the amount of blood that has been lost is difficult and inaccurate, and usually an underestimation of the actual value. But still we try, we try to estimate how much blood is lost from the body, but it is difficult and often inaccurate. Now, what are the different methods? In the hospital, if our patient is bleeding after different type of surgery, after trauma, in a surgical ward, in orthopedic ward, isn't it? Even in gynecology and obstetrics ward, how to determine how much blood is lost from the patient? Very important concept. So let's talk about it. A clot, which is the size of a clenched fist, is roughly equal to 500 ml. So if there is a big clot formation and that clot size is the size of a clenched fist, so it is about 500 ml blood loss. So see there, so 500 ml, okay, a size of a clenched fist. Swelling of closed fracture, let's talk about it now. And this is a very common manifestation after a fracture. For example, fracture femur. Okay, fracture femur. fracture tibia. If there is no compound or open fracture, then that blood is collected in that area. So what is the concept here? Moderate swelling of closed fracture of tibia equals to 500 to 1500 ml of blood loss, whereas moderate swelling of closed fracture of the femur equals to 500 to 2000 ml of blood loss. So this 2000 ml is too much blood loss. Okay, easily a patient can develop hypovolemic shock here. Another way how to determine the blood loss in the hospital, especially during surgery, is the swab weighing. Okay? Swab weighing, and that concept tells us wet swab minus dry swab weight is equivalent to 1 gram, and 1 gram is equivalent to 1 ml blood. Okay, so wet swab minus dry swab weight. So before any surgery, they know how much swab is there, what is the total weight of the swab. They already know that. The helper, okay, the assistant, their job is that. And after the operation is over or surgery is over, okay, if it is soaked with a lot of blood, they take the weight again and they take the difference, and that is how much blood is lost during the surgery. It is estimated. This is one of the ways. And another is a suction drainage. During surgery, the suction drainage is one of the important, instrument there, isn't it? We need to clear that operation site or the surgical area. If there is too much blood, the surgeon cannot see anything. The surgeon keeps on saying, suction, please. Okay, so after the surgery is over, how much blood is there in the suction bottle or the suction drainage? Okay, accordingly, we can estimate how much blood is lost during the surgery. Now, why this is important? It is very important because if the loss is too much, okay, if the patient is showing the pictures of hypovolemia, we need to transfuse the blood. In the beginning, we need to give IV fluid, and later on, we need to transfuse the blood. So that's why we need to determine how much blood the patient has lost. And these are some of the good way. Okay, why hemoglobin level decreases in acute blood loss? Let's talk about this. I already told you it takes a bit of time for the hemoglobin to decrease. Okay, it takes a bit of time for the hemoglobin to decrease. But how much time does it need? Let's talk about it. The hemoglobin level is a poor indicator of the degree of hemorrhage in the beginning, as it represents a concentration and not an absolute amount. So what is the meaning? In the beginning, okay, the hemoglobin takes time to fall. So do not rely on hemoglobin to know the degree of hemorrhage. For example, patient is massively bleeding, but hemoglobin is just, is still 11 to 11.5 gram a percentage. That doesn't reflect the amount of bleeding patient is having. In the early stage of rapid hemorrhage, okay, the hemoglobin concentration is unchanged as the whole blood is lost, and later on the fluid from extra interstitial space, a type of extravascular compartment, and the intracellular space will move into the vascular compartment, and then it will dilute the amount of hemoglobin, then only it falls. So it takes few hours time for the hemoglobin to fall. That's why we keep on telling our students in a surgical patient, for example, in the concealed or internal type of hemorrhage, pallor is a bit late to appear, but once it appears, it really helps us regarding the extent of hemorrhage, but it takes time to appear because the hemodilution takes time to appear. Okay, that's the point. Let's move on. Now let's talk about some of the important, pathophysiology or pathophysiological mechanism of hemorrhage. That means how acidosis occur, okay, how coagulopathy occur, and how hypothermia occurs in a case of hemorrhage. See there? The mechanism of acidosis, if you remember, I've already explained to you. So let's highlight that once again. Hemorrhage leads to a state of hypovolemic shock, especially massive hemorrhage. Usually, if around 2 liter or more than 2 liters of the blood is lost, then hemorrhagic shock will be there. That hemorrhagic shock will cause hypoperfusion of the tissue. Hypoperfusion leads to anaerobic metabolism in the cell, and then it leads to formation of lactic acid, that is called lactic acidosis. It's a type of metabolic acidosis which leads to acidotic condition. This acidotic condition will cause Kussmaul breathing. Okay, the mechanism I already explained before the break. Deep sighing type of respiration. It looks like patient is having shortness of breath, but actually this is a different type of mechanism. Clear? Okay. What is the mechanism of coagulopathy now? Acidosis leads to decreased function of the coagulation protease. Now, coagulation protease means these are the same clotting or coagulation factor which you have studied before. They are the serine protease. So the other term of them are coagulation protease, you can say. Those coagulation factor will not function properly in case of metabolic acidosis. Now what will happen if they cannot function properly? There will be chance of bleeding, and this is called coagulopathy. There's a chance of bleeding when those clotting factors will not form the blood clot. There's a chance of hemorrhage from everywhere. And this is the main mechanism for DIC as well. Now, another important problem is hypothermia. Because of underperfusion or hypoperfusion of the muscle, they cannot generate heat or they cannot synthesize heat, which is the cause of hypothermia. Now, see there, okay? This is a vicious type of circle which is going on there. Hypothermia, okay, can lead to coagulopathy. Coagulopathy can also lead to hypothermia. Coagulopathy is leading to acidosis, and acidosis leading to coagulopathy, and hypothermia leading to acidosis. So these are going on after this mechanism start. Unless we break this chain, they continue to go on for a longer period of time. So we must break the chain, and to break the chain, you need to give good amount of IV fluid. Okay, you need to maintain the perfusion of the cells. As a result of this acidosis will decrease, and then all the other things will fall into place. With this information, let's talk about how to manage a case of hemorrhage. Very, very important concept. This is not a new concept for you. We have talked about this in many different, lectures. But let's combine all these things together and talk, okay? So please pay attention. Very important concept. Why? Please mute yourself. Okay, because of one of the student, everybody is getting disturbed here, okay? Now see this, how to manage a case of acute hemorrhage. For example, you are working in an emergency department, a patient with a massive bleeding, okay, was brought there. What you do? What is the first thing you do? Okay, what else after that? How do you control that hemorrhage? These are very, very important concept, okay? So let's talk about it. First thing is identify the hemorrhage. External hemorrhage, okay, external hemorrhage may be obvious, but the diagnosis of concealed hemorrhage may be more difficult. I already talked about this. External hemorrhage can be seen, but concealed or internal hemorrhage cannot be seen from outside. So this is a challenging type of diagnosis. Any shock should be assumed to be hypovolemic until proven otherwise, because hypovolemic shock is the most common type of shock among all. There are so many other types of shock: septic shock, anaphylactic shock, cardiogenic shock, neurogenic shock. But among them, hypovolemic is the very common one. So we should think about hypovolemic shock in the beginning until proven otherwise. Similarly, hypovolemia should be assumed to be due to hemorrhage until this has been excluded. Other causes of hypovolemic shock are there, like diarrhea and vomiting. Okay, burns, isn't it? But hemorrhage is the first, cause that should come in our mind, because it can be controlled easily if it is diagnosed in time. The second step is a resuscitation. Now we all know the meaning of resuscitation. Resuscitation means probably the vital signs are in disorder now. We need to bring that vital signs back to the normal. What about the airway? What about the breathing? What about the circulation? If we need to take care of all those things. So the first thing is always airway and breathing. It should be assessed and controlled as necessary. Remember, all patient who comes with bleeding in the hospital, they don't have problem in the airway and breathing, but don't take it lightly. If this patient has suffered from major accident, like road traffic accident or motor vehicle collision or something like that, their airway and breathing may be compromised. And if you only focus on the bleeding control, patient may die. So airway and breathing should be assessed always in the beginning. If there is a obvious hemorrhage, you should apply a direct pressure. Okay? That direct pressure will stop the bleeding. Already talked about. Okay, should be placed over the site of external hemorrhage. Now you have to open large bore, okay, cannula or intravenous access, and draw the blood for cross matching. Now let me give a bit of time here. Okay, two large bore IV cannula should be opened on both arms now, and the usual site for the opening of those cannula are where? Where do we put those cannula? Yes, which area? This is in the cubital fossa. Okay, you all know where is the cubital fossa, isn't it? So in the cubital fossa, there is something known as median cubital vein. That vein is relatively bigger and stable type of vein. It doesn't slip easily. So put two cannula there. Either 16 to 18 gauge cannula should be put there. And then they are fixed. And during the time, you should take a bit of blood for the investigation, mainly the cross matching, because we know this patient is going to need blood. Blood should be ready. And for that, blood grouping and cross matching has to be done. After that, we start to give fluid. And the fluid is a normal saline or lactated ringer or ringer's lactate. We give it rapidly, okay, at the rate of 1 liter in 15 to 20 minutes in case of adult. See this? 1 liter in 15 to 20 minutes. This is a rapid type of fluid infusion. In case of pediatric age group, we always say 20 ml, okay, per kg, quickly in 15 to 20 minutes as well. Give at least 2 liters of this fluid in first hour, then you should be happy. Emergency blood should be requested if the degree of shock and ongoing hemorrhage warrants this. That's why you have already done the cross matching. See this, okay? Because you know blood may be necessary here and blood should be requested. So these are some of the very, very important steps. Let's move on. Now, another important, part of the control of hemorrhage is identify the site. Now, there may be some clues from the history. So what are the clues? There may be a previous episodes of similar hemorrhage. Previous episodes. For example, peptic ulcer bleeding. The patient may be a patient of peptic ulcer, and similar type of episodes occurred in the past. Just one example, okay? He may be a non-case of aneurysm, and then this may be a case of ruptured aneurysm. The aneurysm was already diagnosed before. And this is a common place for aneurysm is a abdominal aorta, and that aneurysm may rupture. And once aneurysm is ruptured, there is high chance of death until and unless we treat it in time. the patient may be using NSAID type of drug. Now, let me ask you one question. How NSAID leads to GI bleeding? How?
Sir, NSAID decrease the production of mucus, and that's why it lead to the ulcer.
Good. I agree with your answer. NSAID drugs. Okay, we all know the example of different NSAIDs. Okay, very commonly used in clinical practice. They cause the decreased production of prostaglandins. Okay, prostaglandins. These prostaglandins are a very important barrier for the acid in case of stomach as well as duodenum, and that's why they can easily lead to ulceration there. So if a patient is using chronic or long-term use of these NSAID drug, there is high chance of GI bleeding. Important clue from the history. During the examination, examine for the nature of blood. That is, either it is fresh, either it is black in color, black tarry colored blood, which is known as melena. There is abdominal tenderness, etc. Examine, okay, for the type or nature of the blood. So, fresh blood, if it is coming out from the mouth or in the stool, that means it is relatively active type of bleeding which has just occurred probably few hours ago, or ongoing type of bleeding. If it is a relatively dark colored blood, or which is altered color blood or coffee colored blood, we say, now this has already occurred probably a few hours ago or even few days ago. So these are the important points. For shocked trauma patient, examine for external signs of injury, okay, which may suggest internal hemorrhage. A good example I can provide here is abdominal bruise or contusion. There is a blunt trauma in the anterior abdominal wall, and because of that there is a bluish discoloration, and that blunt trauma has caused rupture of the spleen or the liver, and sometimes even internal aneurysm rupture. Cavitary hemorrhage must be excluded with rapid investigation. If there is a hemothorax, how do you diagnose hemothorax? First of all, I'll examine the chest. I'll examine for air entry. I'll listen for a breath sound. Okay. Then I will take the help of chest X-ray. So these are the way by which I diagnose whether there is hemothorax or not. Similarly, if you suspect pelvic fracture or pelvic bone fracture, go for pelvic radiography. You can see the fracture lines there. Go for abdominal ultrasound. The ultrasound will show you the collection of blood, or diagnostic peritoneal aspiration. Under the guidance of ultrasound you can do. And if blood comes out in that syringe, okay, you always almost know that this patient is having bleeding in the peritoneal cavity. Okay, so until and unless you identify the site of hemorrhage, sometimes the management will be difficult. Now, the important part is control of the hemorrhage. Very important one. You have found out what is the site of the hemorrhage, now how to control it. Pressure and packing is given. This is the first aid treatment of hemorrhage in the beginning, especially in the external type of bleeding. We have to go for this. So this is the first aid treatment of hemorrhage. Never forget it. You can give pressure by your finger, or you can roll a bandage there, a bit of tight type of bandage. Especially in case of variceal bleeding, balloon tamponade can be applied in esophagus. Now, what is the cause of variceal bleeding? Yes? What is the cause of variceal bleeding?
The esophageal virus?
Alcohol, sir, and vomiting.
Exactly. My question is, what is the cause of esophageal varices formation? In which case esophageal varices are there? Yes? Which case?
Portal
Portal
hypertension.
hypertension.
Liver cirrhosis?
Exactly. Portal hypertension caused by cirrhosis of the liver. You can say like that. Your answer is correct. Okay. Don't get nervous. It's because of portal hypertension, and the most common cause of portal hypertension is cirrhosis of the liver. Now, this patient may come to us with a massive variceal bleeding because of rupture of the varices. There are so many different ways how to control the bleeding. One of that is a pressure given there, and that is done by balloon tamponade. And a bit later on, we'll talk about that. And that is called Sengstecken Blackmore tube. Okay, it is a special type of tube there which has got a balloon. So when we inflate that balloon, it will give constant pressure on those variceal, site, so that bleeding will stop. Now, another way of hemorrhage control is application of tourniquet. The tourniquet can be a pneumatic tourniquet or rubber tourniquet. Pneumatic means we feel the air, okay, and rubber is a rubber band. But one important point here, you keep on loosening the tourniquet time and again. Otherwise, there may be a chance of ischemia in that applied area. Another important, way is use of artery forceps or clips, which can be used easily in the hospital, especially during surgery. Use of ligature and suture, very commonly done during surgery once again, and use of diathermy, also known as cauterization or coagulation, and this is done. This will cause electrocoagulation of that bleeding blood vessel, so that bleeding will stop. So artery forceps are clip, ligature and suture, and diathermy, very commonly applied during surgery or operation. Let's move on. Now have a look here. Okay, what can you see here? Look at this special instrument. Look at this balloon here. Okay, this balloon. There is another small balloon there. Then there are some holes present here, and these are the different channels. This is known as Sengstecken Blackmore tube. The Sengstecken Blackmore tube is very commonly used in the management of esophageal varices bleeding. This applies pressure, a tamponade, on those bleeding vessels. Okay, so let me write the name of this structure here. Sengstecken Blackmore tube. Sengstecken Blackmore tube. Okay, we'll talk about this a bit later also. See here, it's very nicely explained in this diagram. This is an important concept for you. That's why I brought this one here. But don't worry, you will study this again when you talk about portal hypertension somewhere. See this. This is the way the tube is put inside. This is the esophageal balloon, which is inflated. This is a gastric balloon, which is inflated. So when it is inflated, definitely it will give constant pressure on those bleeding blood vessel, and bleeding will stop. But one important point, we cannot keep it for a longer time like this. Otherwise, it can give rise to necrosis of the mucosa there. So time and again, we need to deflate it and again inflate it. It has got so many different channels. You can inflate these balloons with the help of some channel, whereas some other channel will be used for aspiration. Just think about it. If there is ongoing bleeding here in the stomach, then we know if we aspirate and if fresh blood comes, we know there is ongoing bleeding there. If a relatively darker type of blood comes, then we know this bleeding is not active type. It has already there, for example, few hours ago or few days ago. Okay, so these are some of the important points. What are the other way of hemorrhage control? We can apply the hemostatic agent like gelatin sponge there. This gelatin sponge will control the bleeding after some time. We can go for the repair of the blood vessel. Repair, okay? Repair of the blood vessel. Again, a type of surgical procedure. The larger vessel and small vessel both can be repaired, but repairment of the larger vessels are easier than repairing the small one. And for the small one, they go for microvascular technique. Grafting can be done to control the hemorrhage, and one of the artificial substance we use is called Teflon graft. Okay, Teflon graft. Actually, this Teflon graft is artificial vessel synthesis for the vascular bypass. That's how it controls the bleeding. And sometimes when we cannot control the bleeding, we have to go for the last resort, and that is excision of whole of the part of the bleeding viscous. Okay, whole of the organ or part of the organ. For example, splenectomy in case of rupture of the spleen, and hepatectomy in case of rupture of the liver. You don't remove the whole liver, okay? You remove only the part of the liver which is bleeding. But we can sacrifice the spleen if it is badly ruptured. Now let me ask you some question here. If spleen is removed, what precaution we need to take? Anyone? Anybody? What happens after we remove the spleen? What happens to the patient?
Sir, we mean
Sir, chances
need
of
blood
infection,
transfusion,
sir,
sir.
absolutely.
Sir, we may need blood
So we
transfusion
will
because
give the vaccine, pneumococcal vaccine,
pneumococcal vaccine,
influenza
yes, sir.
Very
Because
good.
the large infection there.
Good answer. Excellent answer. That's what I want. Look at the role of the spleen there. Why spleen is present in our body? It is a very important part of our immune system. The capsulated bacteria are filtered by the spleen. Many other bacteria are, neutralized or filtered by the spleen. Now, if the spleen is not there, then we are vulnerable to those different type of infection. That's why we need to vaccinate those people. And the common vaccines we use here are pneumococcal vaccine, meningococcal vaccine, and Haemophilus influenza type B vaccine. Never forget this. Okay, so this probably is done, as an emergency procedure. But immediately after going for this removal of the spleen, you vaccinate the patient because this vaccine takes some time to act. Okay, they take few weeks to act. So this is a very important knowledge. Now see there, few of the pictures, how to control the hemorrhage. These are the different, type of tourniquet, okay, tourniquet, different types of pressure bandages, okay. These are, see here, pressure is applied. So these are the different way. This is the surgical procedure. This is called diathermy, okay, or we call it cautery or electric cautery. And if it touch certain tissues or organ with this electric cautery, then there is a electrocoagulation of that bleeder, and bleeding will be stopped. But we cannot stop, bleeding from the big blood vessel like this, okay? Only the small type of blood vessels bleeding can be stopped. And this is known as Teflon grafting. These artificial vessels. Now, if the area which is bleeding is there, then we can bypass that bleeder by putting this artificial vessel. So these are the different way by which we can stop the hemorrhage. This is a very important topic. Okay, so a lot of important concepts are there because hemorrhage or bleeding is one of the commonest